would be Dr. Nabeela T, Assistant Professor of KMCT Medical College, who will be presenting the topic Preserving the Curtains of Eye, that is, the principles of lid repair.
Okay, so a very good evening to one and all. At the outset, I would like to thank KSOS for giving me this opportunity. So, as we all know, ocular trauma is one of the major etiologies for monoocular visual impairment. And tragic headlines like these are very often seen on our waking up mornings, right? And sights like these are not unusual on our day to day travel. And not only road traffic accidents, we have other causes for ocular trauma as occupational injuries, sport injuries, and assaults. And in case of children, we have animal bites and cradle hook injuries as more common causes. So, among the cause of ocular emergencies, trauma accounts for about 33%, and among them, lid lacerations are seen in around 40% of the cases. So, today I will be talking about preserving curtains of eye, principles of lid tear repair. So, before going for a lid tear management, you must be knowing about the anatomy of the eyelid very well. Okay, so just brushing through, you have the outermost skin, then the underlying orbicularis constituting the anterior lamella, then coming the tarsal plate and the conjunctiva constituting the posterior lamella. So the peculiarity of the eyelid skin is that there is no subcutaneous fat and it is the thinnest layer of the body skin. And the orbicularis, it is made up of an orbital part and a palpebral part. And then we have the tarsal plate, which is responsible for the structural integrity of the eyelids, and it is attached on either side of the periosteum by the medial and the lateral canthal tendons. Then we have the levator palpebrae superioris muscle and aponeurosis, which is attaching onto the anterior surface of the tarsal plate. And beneath it, you have the Muller's muscle, which is attaching on the superior border of the tarsal plate. And then we have the orbital septum, which has an attachment from the superior orbital rim over to the levator aponeurosis. And behind it, we have the pre-aponeurotic pad of fat. Similarly, within the lower lid, from the facial sheath of the inferior rectus muscle arises the capsulopalpebral fascia and the inferior tarsal muscle, which acts as a lower lid retractors. And between the orbicularis and the levator complex, you have an avascular plane which is extending onto the eyelid margin as the gray line, which is a very important surgical landmark. So, on evaluation of a lid injury, take a thorough history because mechanism of injury can give a clue to the depth of the wound, and assure the basic airway, breathing and circulation of the patient. Rule out underlying globe injury and get an adequate documentation, preferably a photographic. So the goals of lid tear repair includes eyeball protection, restoring anatomic and physiologic function, and cosmesis. Okay. Now coming to the general principles of lid tear repair. So initially have a thorough exploration of the wound. Okay, so get an extent and depth of the wound. Decontaminate the wound as far as possible. Just flush it with saline and remove all possible foreign bodies. So because of the extreme good vascularity of the eyelid skin, debride only clearly devitalized tissue. And the reconstruction should be done in layers to get a good apposition. And always remember, primary repair gives the best result. So eyelid injuries can be either extramarginal, eyelid margin involving, eyelid laceration with canalicular involvement, or eyelid injuries with tissue loss. So coming to extramarginal, it can be either superficial or deep. Superficial lacerations like this, you just have to oppose it with a non-absorbable suture, a 40 silk or Proli. Just you have to remember that when suturing the skin, the needle should be entered at a slightly outward angle so that it will result in a slight eversion of skin edges so that when the wound heals, it will prevent it from inversion. So coming to deep laceration, you have to gently explore to measure its depth, rule out underlying injury to the eye, orbit or cranial cavity. So wounds which may appear as superficial outside may have an underlying extensive injury like this. In this case, a globe rupture. So a deep wound again extending up to the orbital rim. So when you have a deep laceration, suture it in layers, muscle with a 5-0 vicryl and skin with a silk or proli. So this is a case of a deep wound sutured in layers to give a good apposition like this. So if not done, it may result in a bad wound like this where you can see tissues protruding in between. So this was a wound which came, it was opened up, resutured in layers to give a very good apposition like this. So now you can have wounds like this where you have an orbital fat prolapse. So once you get wounds like this, one thing you have to remember is that at least the orbital septum has been breached. Okay, so in these cases, the fat must be cleaned and reposited gently, and the orbital septum is not sutured because it may result in a lid retraction and lag of thalamus. And if you have an underlying levator injury, it must be sutured over to the anterior surface of the tarsal plate, or else it may result in a ptosis. This is a case of an 8-year-old girl with a cradle hook injury. You can see fat prolapse. Luckily, there was no underlying levator injury. It was cleaned and reposited back, wound sutured in layers to give a good postoperative outcome. Now, in cases like this, here it is a 28-year-old male with an occupational site injury. You can see a steel wire piercing the eyelid. So ideally, you have to go for an imaging to know the depth of penetration of the foreign body. So here, in this case, it was a steel wire with a double entry through the eyelid, and luckily it was only superficially touching the sclera with a partial thickness wound. So this just the wound either side of the steel wire was extended, foreign body removed, sutured and left. So coming to eyelid margin involving lacerations, initially you have to identify the gray line, pass the first suture through the gray line, preferably a vertical mattress suture using a 6-0 or 5-0 silk. And then pass sutures anterior and posterior to the gray line. Certain surgeons prefer only 2 sutures. And these sutures are left long. Okay, then you suture the tarsus, which should be a partial thickness suture. This suture must at least pass 2/3 thickness, but not full thickness, otherwise it will rub the cornea. Then you have to suture the skin and orbicularis, and the marginal sutures are left long, and these are tucked under the skin sutures. One thing you have to notice, after suturing, the sutured wound must result in a lid pout. Only then the plane of scar will come in line with the eyelid margin. So a good apposition with slight margin eversion should be the goal. So again a case, a 9-year-old boy with a cradle hook injury, wound sutured in layers with a postoperative 1 week. Now, when you have a canalicular involvement, when do you suspect these? When you have lacerations medial to the punctum, or when you have a lateral punctal displacement, or in case of bite injury. So whenever you suspect, probe to rule out canalicular injuries. And canalicular injuries mandates primary repair, otherwise it will result in lifelong epiphora. And identifying the proximal end of lacerated canaliculus is a difficult task at times. So what are the methods? You can examine under good illumination and high magnification to see a white circular puffed out edge. Okay, or you can irrigate fluid or air through the uninjured canaliculus and see where the jet of water is coming through. Or you can pool normal saline in the medial canthal area and inject air through the intact canaliculus. Or fluorescent dyed normal saline or viscoelastic is injected through the intact canaliculus. So whenever you do a canalicular injury repair, always possible, usually a stent. Okay, so the stents it can be used are a mini monoca stent, which is usually a monocanalicular stent, or a Crawford bicanalicular stent, or even an angiocath IV cannula can be used. So whenever we are going for a lid canalicular repair, initially do a punctal dilatation and probe through the proximal end to confirm whether it is going to the sac. So just to show a video. So this is a stent. You can cut the end to make it a beveled edge for the easy entry. So this is passed through the distal cut end and just pull it so that it gets plugged within the punctum, and the coloretta is staying in flush with the eyelid margin. Okay, then the distal end is passed through the proximal, earlier identified proximal cut end. Okay, then you have to suture just anterior and just posterior in the pericanalicular area, resulting in a pericanalicular anastomosis, and the rest of the layers are sutured. So this was the case, a 28-year-old male with a history of fall from bike. The repair was done using a mini Monoca stent, and the external layers were repaired in layers. So this is a post-operative 1 week. Okay, now when we don't have stents in hand, can we use any other materials? Yes. So this was a case which is an upper lid full thickness injury and a lower canalicular injury, and here it was cannulated using a number 1 proline suture. Okay, so this was a post-operative picture. You can even use our usual IV cannulas, 24 gauge and 22 gauge, where the Teflon sleeve is used as a canalicular stent. Just that you have to secure the tube to the skin by the sutures. But the extrusion rate is high and patients may get inflammation. Another thing to remember is that canaliculus is closely related to the medial canthal tendon. So you may have medial canthal tendon injury associated with a canalicular injury. Okay, so here this is the anterior crus of the medial canthal tendon. Just behind that you have the lacrimal sac and the canaliculus, and behind that the posterior crus. So if at all there is a medial canthal tendon injury and you haven't repaired it, you may get a residual defect like this. Okay, so make sure that the medial canthal tendon is not injured, and if at all it is injured, at least make an effort to attach the posterior crust to the posterior lacrimal crust, because that is the one which gives the integrity of the medial canthal tendon. So when you have tissue loss, for small defects you can do a direct closure or a lateral canthotomy with a cantholysis. For moderate defects you can go with a tensile semicircular flap, and for large defects you can go with flaps like mustard cheek rotation, Hughes tarsoconjunctival, or a cutlet beard flap. So just finishing off with an interesting case, we had a 48-year-old male who presented with a small lid abscess in the right eye for 2 days duration. An incision and drainage was done. He had a history of road traffic accident 2 weeks back, during which he had sustained an injury to forehead and it was sutured, but he had no history of injury to lid at that time. He came with a recurrence of the swelling 1 week later. A repeat incision and drainage was done, and we could find a tract which is going upwards from the site of the lid abscess. The wound was extended and explored, to our surprise to see a foreign body coming out through the wound. So it was a button on the raincoat which he was wearing during the accident, which was accidentally incorporated within the wound, and which would have tracked through the subaponeurotic plane downwards to the lid between the tarsus and the orbicularis. So finishing off with a take-home message, always rule out a globe injury before proceeding for a lid repair. Primary repair is the best repair. Repair all canalicular lacerations whenever possible, and minimal tissue sacrificed in avulsed injuries is the rule because of the excellent vascularity of the lid. So an early, meticulous, primary restoration of anatomy is the key to success for a lid repair. Thank you.
Thank you, Dr. Nabeela, for this very informative talk.